Okay. Good evening.
Good evening, sir. Good evening, sir.
Who is Vignesh? Who is Nitin?
This is Vignesh, sir. I am Nitin, sir.
Okay. Did you present before or first time you are presenting in this Zoom session?
First time we are presenting.
Presenting. So naturally slightly anxious.
Yes, sir.
No need to be anxious at all. Don't worry.
Okay.
Because even if you don't answer, I'm there to answer everything. That is there. This is not an examination or anything. It is just for you to have an experience of how to present and what questions will be asked for you in the exams and what answers to be given and how to answer. And these are the things which definitely help you in facing the exam. Of course, you're not going to face the exam immediately. Your exams are quite good. But still, repeatedly, when you start, exposing yourself to many other teachers or even examiners, like mock exams and all. So it's going to help you a lot when you take the exam and actually you will be presenting the cases in the exam. Okay, so previously, last classes, any doubts for anybody? The previous classes we had already done. Many classes we have done almost all the long cases except liver. Liver has to be done yet. So all the long cases we have finished. So majority of the short cases also we have finished. And today, tomorrow, we are going to complete pediatric anesthesia. The short cases as far as pediatric anesthesia is concerned. So any doubts regarding the previous sessions, what we had? For you, Vignesh and Nitin? For the previous sessions?
Yeah, we are there, sir. We are attendance.
So did you have any doubts which is carried now, which
No,
can
sir.
be discussed?
No, sir.
Okay. Everything is clear.
Yes, sir. Your presentation.
Very good. So just we'll wait for 5 o'clock and then we will start at exactly 5.
Sure, sir.
So, that's why I just, wanted to ask about. And in a pediatric case, because today you're presenting a cleft lip palate, and that's why I wanted you to present the cleft lip palate first because it's a small child.
Yes, sir.
6 months. Tons we usually do after about by 5 years, not just like less than 5 years, adenodectomies, the children are posted, and after 5 years, many times these children are posted for tonsillectomies. And older children, not much of a problem. It is always the problem is when the child is an infant, like less than 1 year. You have a lot of problems because the physiological changes, anatomical changes are there when compared to an adult patients. So all those things you'll have to keep in mind when you are managing these pediatric cases. So that's the reason why I asked you to present first the lip and palate, and later tomorrow we can take up the the tonsil. Suppose today we are not going to, or this thing gets extended. So briefly tomorrow we can continue the lip and palate, and afterwards tonsil we can take up, because most of the thing in pediatric would have completed today itself, and for tonsil will not be taking much time. So it may get extended if required for tomorrow, and you people may have to be there again tomorrow for first maybe about half an hour, and then I don't expect we may finish today itself, but you never know. So that you be prepared. Okay, then it is exactly, I think, 5 o'clock. So all the short cases, what you do is you present the short case. You need not have to tell about the investigations. Investigations are not given to you in the exam. You are given only the child will be there with the attendant, and you have to take the history from the attendant, and you have to examine the child, and then you have to present. And majority of the times you should present very important history and also important things as far as the examination is concerned, which can affect you as far as your anesthetic management is concerned. Those things you'll have to give more importance whenever you take history and examination, because many times you may be asked just to tell what is your case, and then you may be started examined by the the examiner. He may start asking you questions, just asking you, okay, you will say that your case is a left-sided cleft lip with incomplete palate defect. So then they may start asking you questions. Or some of the examiners will ask you what are the important findings in the history, positive findings, and important positive examination. You just tell only that, because total time given for a short case presentation is only 15 minutes. Of course, today we will be discussing for 2 hours. That is different, so that any question that can be asked for you in that 15 minutes. So we will be discussing all the different kinds of questions, so that even any of these questions is asked in that 15 minutes, you should be ready to answer. Okay. So who is going to present this particular case?
So Vignesh will be presenting, sir.
Okay, Vignesh. Just read whatever you have taken the history examination. Don't worry about the investigations. We'll discuss about the investigations.
Starting.
Samira,
Yeah,
6 months old female child.
Start.
Sir, Samira, 6 month old female child, weighing 7.5 kg, brought by a mother Bhanupriya, who is also the informant with a low socio-economic status, residing in Kadlur. The baby mother gives the history of difficulty in feeding, history of nasal regurgitation during feeds, and recurrent upper respiratory tract infection for the past 6 months.
History of presenting illness. Patient with the history of nasal regurgitation of oral feed for past 6 months, history of recurrent URTA, history of feeding difficulty. Child is able to sleep comfortably in the supine position. No history of snoring. No history of discoloration of fingers, toes on crying. Past history. Child was initially taken to the outside hospital for similar complaint 6 months back, and she diagnosed as having cleft lip and palate. Birth history. Baby was full-term non-vaginal delivery with a birth weight of 2.28 kg. Baby was cried immediately after birth. No other associated abnormalities. Antenatal history. Non-consanguineous marriage. Primary and regular checkup. Regular follow-up with no significant history. Achieved age approximate milestone. No developmental delay. Immunization history. Immunized up till to the age. Family history. No history of similar complaints in any other family members. Clinical examination, general examination, child is active, alert, interact with the environment, afebrile, no pallor, no ictus, no cyanosis, no clubbing. Height is 68 centimeters, weight of 7.5 kg, head circumference 42.8, and heart rate of 110 beats per minute. Examination of face and oral cavity, left side unilateral cleft lip and incomplete prepalatal cleft palate involving alveolus and nostril. There are no obvious external congenital anomalies. Systemic examination, CVS S1, S2 heard, no murmur, no pericardial bulge on parasternal leaf. Echo shows normal. Respiratory system, normal vesicular bed sound here, no added sounds. Investigation. Next.
Investigations, don't worry. Yeah.
6 months old infant of weight 7.5 kg with history of nasal regurgitation during feeds and history of feeding difficulty and the recurrent URTA. Based on the history and finding, this is the most probable case of left-sided unilateral cleft lip and incomplete prepalatal cleft palate, not associated with other congenital anomalies, post for lip and palatal repair surgery.
Okay, so but don't say that most probable. You should already, it's a definite
Diagnosed.
left lip palate. It need not be most probable or anything. Okay,
Thank you,
so
sir.
few of the things as far as your history you have taken very well, and most of the things you have taken. And few things like one of the important things probably you should have taken is, because you have said that recurrent upper respiratory tract child is.
Yes, sir.
First of all, why upper respiratory tract infections are more common in this pediatric, particularly cleft lip palate surgery? Why
because
do
they? Because of the nasal regurgitation and the more chance for aspiration.
One is
so,
nasal regurgitation. The other thing, the
Okay.
direct communication between the
Between the
oral cavity and the nasal cavity.
Nasal cavity.
So the infection can easily pass from the oral cavity into the nasal cavity. Yes. Second thing is because of repeated because of the regurgitation into the nasal cavity or nasopharynx because of the palate defect also. So that's the reason why they are prone for repeated upper respiratory infection. So why you should know is another very important thing you should have taken the history is when was the last severe upper respiratory infection? That is one of the very important positive you should always present because you have not taken that. You have just written that, yes, repeated recurrent laryngeal upper respiratory infections, but when was the last, severe upper respiratory infection? You have not written. Why is it important to, ask about the last severe upper respiratory infection?
We should postpone surgery at least 4 to 6 weeks. After that, only we have to proceed with surgery, sir.
Now, what is the present thinking? Is it 4 to 6 weeks or just 2 weeks?
Actually, ideally 4 to 6 weeks, sir. We can postpone up to 2 to 3 weeks.
Yeah, usually nowadays, even the latest Miller 2024 edition, he has given more than 2 weeks of postponement is ideal. Though in the older books, it is said that at least 6 to 8 weeks of postponement. But why to postpone?
Because in active URTA, vagal nerve endings is hyperstimulator. So
Sensitive.
hypersensitive. So more acetylcholine will act on M3 receptor, more chance for the bronchospasm, sir.
Now, why more acetylcholine will be released? When more acetylcholine will be released?
Because of that, because of parasympathetic.
No, you are correct in telling that, the vagal nerve endings supplying the branchial smooth muscles will be hypersensitive. So naturally, they can release more acetylcholine, which can act on the M3 receptors and can produce bronchoconstriction. That is fine. So when this occurs, what stimulus?
During active phase of infection because of the viral.
This is okay. What is the stimulus which can release? There has to be some stimulus. Otherwise, just like that, there won't be release of more amount of acetylcholine.
By airway manipulation, sir.
That you should say because you are going to do the airway manipulation. When you do the airway manipulation, there is always a possibility of bronchospasm. Severe bronchospasm can occur because hyperreactive airways is there. The other thing is that the child also can go for laryngospasm. Mainly the bronchospasm, but also the child can develop laryngospasm, breath holding. All these are very common when the child has got a recent upper respiratory infection or presently also it has got upper respiratory infection. But one thing you should realize that upper respiratory infection will be there till the defect is repaired, isn't it? Because the continuous the problem, the pathology of the recurrent infections will continue and child will never have a day without an upper respiratory infection. But when can you take up? When you want to postpone? Suppose if a child there will be rhinorrhea, will be there. So when do you think that the child should not be taken up and it should be postponed for at least 2 weeks?
With a clinical total count should be higher as well as auscultatory findings will be there. Means we will postpone.
No, there are 4 criteria are there for postponing. One is if the nasal discharge is purulent. It's not mucus discharge, but it is purulent nasal discharge. One criteria. The second criteria is the child is running fever. That shows that both are active bacterial infections. And third thing is, as you said, there is a extension of this URI into the lower respiratory tract, wherein you can hear bronchi and crepitations in the lungs. Then also you may have to postpone, and as such, the total count is higher. So more than 10,000 total count. So these are the 4 criteria. If they are there, it is better not to take up because lip repair or palate repair is an totally elective surgery. They are not emergencies. So once they are not emergencies, there is no point in taking up with the child you think that may develop an intraoperative bronchospasm. So that is why these are the 4 criteria you should remember. The other important thing about your history is that the antenatal history also becomes important, especially the mother, if she has taken any drugs, though it may not, produce anything as far as or change in your anesthetic management, but it is very common that many of the examiners are fond of asking you, especially the drugs which can produce teratogenicity, and especially certain drugs are, involved as far as the cleft lip or palate defects to occur in the neonates. So what are the drugs which produce actually these, if the mother has taken these drugs in the first trimester or organogenesis period? Anti-epileptic drug, correct?
Warfarin, alcohol.
Alcohol is. Then anything else?
Antipsychotic.
No, steroids.
Steroids.
Steroids, benzodiazepines.
Benzodiazepines.
Yeah, benzodiazepines and steroids very commonly being used by many of the women, and especially steroids if the mother also has some problem like collagen disorder or anything which she requires continuous steroid therapy, which she may not be able to stop during the first trimester. So that is one of the common things that it is always better you can inquire about. The other thing is about the ear infection is also very common in them. Frequent ear infections, because once the pharynx is also involved, or the cleft palate extends into the soft palate also, so eustachian tube gets affected. These children will have repeated ear infection also, and that may also can produce ear discharge continuously, and also can lead to deafness also for these children. So that is another very important thing which you have not asked. Just remember about that, just to ask about that. So the other thing is you have asked about history of difficulty or snoring for the child during sleep. So why did you ask about this? Obstructed airway problems. So you have asked that, isn't it?
Yes, obstructive.
Why did you ask about obstructed airway in this?
For airway assessment.
No, what suppose if the mother gives history of the child having difficulty to sleep because of it starts snoring and wakes up in between, and position has to be changed, or even many times maybe kept in the prone or in the lateral position. So you can expect a very difficult airway. And many times you may not be able to go for giving muscle relaxants before you intubate. So you maintain the patency of the upper airway by giving only an inhalation, going in for an inhalation induction, and maintain the respiration of the child. So that is another very important thing. So that you have asked. And the other thing also you have asked is about the congenital heart disease, history of any, cyanosis or child not thriving. Of course, many other things which are there in the congenital heart disease will also be there in a child with a cleft lip palate, because again, nutritional deficiency, failure to thrive, and repeated respiratory infections are very common in the children with congenital heart disease also, and also in children with cleft lip palate problem. So anyway, that is very important, because associated congenital heart disease, if it is there, it will add on to our method of management. Method of management may have to be altered. And one more thing is, it can run in families, and it can be hereditary also. So when a father has a cleft lip, invariably the first male child will also have a cleft lip. So the first male child. So that is another thing which you have to keep in mind. Okay, so another thing about in the examination, you should have look for the veins for cannulation. So it is very important in all pediatric patients that you identify during your examination which vein you want to cannulate, because you have to, because getting a intravenous cannulation is one of the most difficulties in pediatric. There are two problems in pediatric anesthesia. One is getting an IV line. Second is getting an airway, getting into the airway. So these are the basic problems. If you can get both of these, so your 50% of the pediatric anesthesia is almost over. So that is why when you are examining the child, so you should always look for the probable in the vein which you want to cannulate. And that is very important when you're presenting in the examination also. And you have to even mark that vein. And mark that vein, and also because you have to tell the nursing attendant of the ward not to use that particular vein. Otherwise, you would have seen a particular vein on the dorsum of the hand, and by the time you bring the child to the operation theater, that there will be multiple punctures there, and that vein would have been used. So again, you will have so much of difficulty in identifying another vein. So that is why that particular vein you will have to mark, and then you have to tell the attendant not to use. That is one thing. And second thing is, once you have identified that particular vein, it is always better to put a Emla cream also over that about an hour or 45 minutes before, so that when you want to cannulate, it will be a painless cannulation of the vein, especially in a child who is just about 6 months or less than 6 months. You can even get an IV line before actually going in for anesthesia. Older children, they will not know, but younger children, less than 6 months, but provided you have used an Emla cream there. What is Emla?
The Emla cream causes vasoconstriction. So
No, it may not produce any vasoconstriction. Have you seen any vasoconstriction when you placed Emla cream?
it produces vasoconstriction.
No, not much, not much. Because if you have properly applied, how do you apply Emla cream? Anyway, let me ask you.
So applied over the vein dorsum, we wrap it with the tissue gauze, sir, for around 45 minutes to 1 hour.
No, just before placing the gauze, anything you have to place? No, because if you apply immediately the gauze, everything will be absorbed into the gauze. So nothing will penetrate the skin. So in order to avoid this, so you have to use a plastic, small plastic sheet, cut plastic sheet over the Emla cream, and over that you have to apply.
Sure.
Yeah. So that is definitely is going to help. Not much of a vasoconstriction occurs because locally your lidocaine and prilocaine, they are vasodilators. Locally, because you are using Emla cream contains mainly the prilocaine 2.5 and lidocaine 2.5. They are basically locally they are vasodilators. That's why many times you will be using adrenaline along with when you want to infiltrate, because local vasodilatation occurs, absorption will be rapid, duration of action of the local anesthetics will come down. That is the reason, in order to produce local vasoconstriction, you will be using epinephrine, isn't it? Along with lidocaine with epinephrine when you want to use an infiltrative anesthesia. So that is not a concern. Don't worry about that. But application, because then you can get an IV line before induction of the anesthesia. If you can get an IV line, you can even go for IV induction. Because many times the children are brought into the OT without an IV line, and you have to go for inhalation induction and get the IV line. So, but if you have an IV line, you are more, safe as far as managing these children are concerned, isn't it? So, half of your anesthesia concerns are, over once you have an IV line before. So that is another very important thing. You should always look for a proper IV or a vein for cannulation that you have to write down there. Okay, so these are the things which keep it in mind while taking history and examination of these children. So let us just discuss about this particular case. So this child has got a lip and then a palate, both.
Yes.
Isn't it? So just let me ask you about the incidence of cleft lip and cleft palate. So what is the incidence of cleft lip alone and cleft lip palate together?
1 in 500.
Not so common. If it is 1 in 500, you would have found more number of children with cleft lip palate. It is usually about 1 in 2,500 to 1 in 3,000. And cleft lip palate, cleft lip is more common. Cleft lip palate is slightly 1 in 4,000 to 1 in 5,000. So that is one thing. And second thing, I just want to ask about the gender and then the lip and palate. Of course, these things do not have any effect as far as your anesthesia management is concerned. But these are some of the questions can be asked for you in the exam. So it's better you know about it.
Females.
So, females, which is common?
Cleft palate.
Cleft palate alone. Cleft palate alone is more common.
In
In females, almost 3:1. How about cleft lip alone?
Males.
Yeah, cleft lip alone is because you said cleft palate alone is in females. Cleft lip alone is more common in male children. And cleft lip and palate together can be equal as far as the gender is concerned. It can occur in both. Okay. Now, which particular side of the cleft lip or palate, or especially the lip, let us say, is more common? Is it left-sided lip is more common? Right side?
Left-sided, sir.
Left-sided cleft lip is more common. So, as far as the cleft lip is concerned, suppose if you want to anesthetize, which particular side of the cleft lip you think it may be more problematic for you? Is it the right-sided cleft lip or the left-sided cleft lip?
Right-sided cleft lip.
Right-sided. Why do you think? No, you have to reason it out. It's not just say something. No, because I'll just give you a clue. So when you do a laryngoscopy, you introduce the laryngoscope blade through the right angle of the mouth, isn't it?
Yes, sir.
Then move the blade towards the left.
Left side.
So when you are moving towards the left, the blade may get stuck in which particular side?
Left side.
Left side. You see, you are moving to the left, isn't it? Though you are introducing through the right side, but afterwards you are moving towards the left. You have to take the tongue push the tongue to the left.
Left side.
It is always, what people have found is, including me, the left-sided one is slightly more difficult because your blade may into that cleft and, there may be decreased maneuverability of the blade. So that is one thing. And how about the bilateral cleft lip? Is it more difficult?
Yes.
Bilateral cleft lip premaxillary tab. The premaxilla will protrude like this. That is called as a premaxillary tab. That is extremely difficult one. Of course, we are not talking about the syndromes. Of course, the syndromic babies will have more difficulty. But bilateral cleft with a premaxillary tab, which is protruding downwards, is one of the very difficult as far as the lip is concerned. Okay. Now, how do you classify the cleft lips? How do you classify the cleft lip?
Unilateral, bilateral.
Yeah, one is unilateral and bilateral. Okay. Then?
Complete.
Yeah.
Partial.
Complete and incomplete.
Incomplete.
So when do you say it's complete? When do you say it is complete? When do you say it is incomplete? It is complete.
Entire lip into the nostrils.
Yeah, when it extends into the nostril, the cleft lip, it is called as a complete cleft lip. When it is not extending, only rest of the lip, then you call it as an incomplete cleft lip. So again, when you are diagnosing, these things becomes important because a complete cleft lip will have more difficulty as far as laryngoscopy is concerned compared to incomplete. And another thing is the recurrent respiratory infections are more common with complete cleft lip when compared to the incomplete because there is a direct communication between the oral cavity and the nasal cavity. And how do you classify the palate, cleft palate?
Pre-palatal, palatal, post-palatal.
Okay. Unilateral and?
Bilateral.
Bilateral. Complete incomplete also.
Okay, sir. Okay.
Yeah, complete incomplete, pre-palatal or post-palatal.
Palatal.
How do you know whether it is pre-palatal or post-palatal?
Involvement of the soft palate also.
No, how do you differentiate between the pre-palate and the post-palate, or primary palate and the secondary palate? Pre-palatal is the primary palate.
Primary.
Now, what differentiates this primary palate and then the secondary palate?
Primary palate is from the.
No, it is the incisive
So,
foramen. Anterior to the incisive foramen is the primary palate, and posterior to the incisive foramen is the secondary palate. And secondary palate also includes the soft palate. Secondary palate also includes the soft palate. So whenever the secondary palate is involved, that is a post-palatal cleft palate, it also involves the soft palate. If it is only pre-palatal, it need not have to include the soft palate. It is anterior to the incisive foramen. So that is another very important thing. Okay. Can you just tell about the basic embryology in one sentence about the lip, cleft lip, and one sentence about the palate defect, embryology?
Cleft lip is due to the failure of the fusion of the medial nasal prominence and the maxillary prominence. Cleft palate is
process. Failure of fusion of median nasal process with maxillary process. Okay.
Cleft palate is
in the middle line. Maxillary process are on either side. So if there is a failure on any one side, it can be unilateral. If it is failure of fusion on both sides, it is bilateral. Okay. What about the palate?
Palate is due to the failure of the fusion of the two palatine sleeves. It's
palatine shelves. Yeah, failure of fusion of the palatine shelves is actually the one which you can say that can produce, palate. Okay, usually when these children are taken up for surgery, lip surgery when they will take up, palate surgery when they are going to take up.
Lip surgery can be taken up after 3 months. Palate surgery will wait for up to 10 months.
Lip surgery can be done even less than 3 months. One need not have to wait up to 12 weeks. Usually it is taken up after 6 weeks, anytime after 6 weeks, as early as possible, because, why lip surgery is done early?
Because of the nutritional status, baby will not suck easily, as well as cosmetic issue, as well as
cosmetic is not a problem in babies, isn't it? It is slightly older children.
Like if you do surgery earlier, it will decrease the width of the palate defect.
Basically, the child can create a negative pressure for suctioning the mother's
don't reflex.
So that, mainly for nutritional purposes, as early as possible, the lip surgery has to be corrected. So that is the reason many times the child is taken up after about 6 weeks. Why not immediately after birth?
We need to rule out any congenital anomalies is there or not.
No, even immediately after birth. Intrauterine you can many times. Left lip can be identified intrauterine also.
We not immediately. We can give for artificial feed through palade like that. We can manage.
Any surgery in a neonate is slightly more riskier and also can produce more problems for the baby. Neonate, 4 weeks. So you want some amount of anatomical development of the baby so that, the complication rate can be decreased. That is why, you don't take up the baby very early, like a 2nd day, 3rd day as a neonate. So many times you want to have the baby to complete that 4 weeks. So that is why after 4 weeks, anytime the child can be taken up for lip surgery. For palate surgery, why wait till 10 to 12 months, you said?
Like the palate surgery is a major surgery, sir, compared to lip surgeries,
Very
as
good.
well as a more major bed loss may be occur, as well as the during earlier stage the palatal tissues are very fragile, sir. We need to wait for and as well as we need after 6 months only speech therapy, speech development will occur. Before that, we need to do surgery.
Especially the soft palate.
Soft
Soft
palate.
palate is very important for speech. So many times they go for two-stage procedure. First, the soft palate is done along with the lip surgery itself. And later, maybe after about 18 or 20 months, that is 1.5 to 2 years, the hard palate surgery is taken. So that, the development of hard palate also will be better if the surgery is done later. Otherwise, early fusion of the palate, so the development may not occur, or there may be a problem with the development of the palate, hard palate. So that is one thing. And whenever you take up these children, many times you will be asked in the exam about the rule of 10.
Yes, sir.
So who introduced this rule of 10? It is based on whose name?
Killness.
Kilner's rule of 10. So can you just elaborate Kilner's rule of 10?
So 10 lbs weight, 10 grams of HP, and 10 weeks.
Pounds. 10
10
pounds.
pounds.
Okay, don't say LBS.
Okay.
Okay, right. Now, how do you convert pounds into kgs?
10 pounds is 4.5 kgs, sir.
How did you get that?
Mhm.
No, you should know the conversion factor, isn't it?
Yes.
Because usually we don't go with pounds in India, isn't it? We always go with the kgs. In Europe, probably in UK and all, they go with the pounds. So in order to convert that, you divide these pounds by 2.2 to get in kgs. That is what you said. 10 pounds divided by 2.2 roughly is about, as you said, about 4.5 kgs, slightly less than 5 kgs. So that conversion thing also you may be asked, so better to know. Okay, 10 pounds for lip, 10 pounds of weight, then 10 weeks of
Age.
age. Okay, then
10 grams
Hemoglobin.
HP. 10 grams
10
per
grams of
deciliter.
hemoglobin per percentage. Okay, then
Total count should be less
Less
than
than
10,000.
yeah, total count should be less than 10,000. What is the change for palate surgery
Change.
in this rule of 10?
We can avoid less than 10,000 counts.
No, all these things same except the age.
Age.
Instead of 10 weeks, you go for 10 months
10 months.
for palate surgery. That is the only difference of rule of 10, Killer's rule of 10 as far as palate surgery. And so everything is very important here because, you want a sufficient amount of hemoglobin so that, maximal allowable blood loss can be sufficient enough. And the infection should not be there. That is why leukocytosis you look for. And age of the child is also already we have discussed why 10 weeks and why 10 months. So these are the important things because nutritionally there will be a lot of problems for these children. Of course, the child you are presenting has got 7.5 kgs and it is 6 months. Is it normal weight gain or it is lesser weight gain? Usually, what is the weight gain by about 6 months?
Double
the birth weight.
Yeah, by 5 months, it is twice the birth weight. And by 1 year, it is thrice the birth weight. So as far as the average gain of body weight, it is okay. Your child has got 6.5 kgs, isn't it? So that is okay. And another thing what I just wanted to ask you, you have written that the height of the child is 68 centimeters. You have presented, isn't it, in your presentation? Yes. So why it's important for you to know 68 centimeters as the height?
Because of body surface area.
No, you don't have to, you don't calculate anything in the body surface.
Because any syndrome.
No. It is for selection of the endotracheal tube size.
Tube size.
Height in centimeters divided by 20.
Yes.
19 centimeters divided by 20 should be your endotracheal tube. So suppose now 68 centimeters divided by 20 is 3.8 centimeters. So you can take a 3.5 cuffed endotracheal tube. Sorry, 3.5 uncuffed or a 3-number cuffed endotracheal tube for this child. So that is why height becomes important for this particular child. So that you have measured height and head circumference also you have measured just to rule out any hydrocephalus for this child, or microcephaly also is, some of the syndromes can be associated with microcephaly. So that's why you have measured. Okay, the other important thing is many of these children with cleft lip palate may be associated with syndromes.
Yes.
Isn't it? So what are the most common syndromes and why should you know about these syndromes?
So Perry-Robin syndrome, Tetzel-Pollin syndrome, Golden Hair syndrome, Patau syndrome,
Okay.
Fetal
Down's fetal alcohol.
Down syndrome, and other thing is catch-22 syndrome, charge syndrome, Vector. All these syndromes may be associated with cleft lip palate, and especially Peary-Robbins. What is Peary-Robbins sequence?
So glossoptosis, micrognathia, and cleft palate.
So what is
Sequence like?
sequence is a multiple
I think
anomaly which is
what is
caused
the
by the
primary-
single anomalies.
So what is the primary problem that produces a sequence of maldevelopments?
Micrognathia, sir.
Yeah, micrognathia or hypoplastic mandible. That is the basic thing that is the beginning of the syndrome. So because of micrognathia or retrognathia, what is the problem? What happens to the development of the tongue?
Tongue which pushes anteriorly.
Yeah. No. Tongue is pushed posteriorly because
Posterior.
will not have enough space anteriorly.
Space.
So its attachment will be more posterior.
Lots of process.
So that is the reason it will be falling backwards. Glossoptosis means what? Ptosis.
Ptosis, falling backward.
There won't be any macroglossia. Tongue size will be normal, but it is attached slightly more posteriorly and it will be falling backwards. And also, because it is being pushed upwards, it is not allowing the palatal shelves to close. So that is why you have a cleft palate. So micrognathia and glossoptosis, and then the cleft palate is very, very common with Peary-Robin syndrome, and associated there can be congenital heart disease also. Now, why should you know about Peary-Robbins?
Most common.
So what if the child has got a Peary-Robbins syndrome? Have you anesthetized any child with Peary-Robbins? So have you anytime in this?
No, sir.
That is why you don't know the difficulties. What difficulty you will face as far as the child with a Peary-Robbins syndrome?
Difficulty in intubation, sir.
Extreme difficulty as far as laryngoscopy and intubation is concerned. There may be some difficulty in holding a mask also because the micrognathia is there, but most important thing, and of course, there will be a problem because the tongue also will be falling back. Patency of the airway maintenance will be very difficult even with mask ventilation. But most difficult thing is, when you are trying to do a laryngoscopy, you may not be able to, visualize any part of the larynx because larynx is extremely anteriorly placed. So that is one of the most difficult thing as far as the Peary-Robin syndrome. And another problem with Peary-Robin syndrome is as soon as a child is born, the child will have respiratory distress because the tongue will be falling back and obstructing the upper airway. So the child is having respiratory distress. Anything is being done to prevent the tongue falling back? Any surgery is being done for the baby as soon as it's born? The first day or second day itself?
Tongue stitch.
Tongue is stitched to which place?
The lower
gum. Either lower lip or the lower gum. The tongue is, pulled forwards, and it is, the suture is placed with the tongue to the lower gum, lower part of the mandible. so that, that when the child lies in the supine posture, the tongue will not fall back. So that is one thing. And when you are taking up for this particular child for surgery, that whatever the stitch that has been placed has to be released. Otherwise, you will have, again, more difficulty to do a laryngoscopy and intubation. So that is the reason why you should know whether this has been done or not. So how this is done? What kind of anesthesia is being given for suturing anteriorly of the tongue to the lower gum? No, many times, because it's a very small child, 1 day or 2 day old child. So many times they just do under local anesthesia because 1 or 2 just stitches they have to take. So you need not have to give complete general anesthesia for such children. So just it can be done very rapidly by the pediatric surgeons. So that is, but you should know that that kind of a surgery has been done for the child initially. So, okay. So that is about the peri-Robbins. And suppose, especially in these micrognathia children, how do you know that your regular routine laryngoscopy, you may not be able to visualize anything. Then how do you plan to intubate such children?
See, my video laryngoscopy can be used.
Even with video laryngoscope, many times you may not be able to visualize. That I have seen. Unless you have a hyperangulated video laryngoscope, you may have to have. With a hyperangulated video laryngoscope, sometimes it will be, it is possible to visualize. Recently, we had a case, even with the hyperangulated blade, we were not able to visualize any part of the larynx. That is one of the most difficult, airways for laryngoscopy intubation. Many times you may have to go for the rigid laryngoscopy that is used by the ENT people. So only through that you can intubate, or you can use your supraglottic airway device. You can just place a supraglottic airway device. Through that, you can pass your fiber optic scope and then identify the glottic opening. And then over the fiber optic, you may have to push the endotracheal tube. So that is because why these things are important is because you have to keep all these things ready. Otherwise, it will become very difficult. You may not be able to intubate unnecessarily. You will have to postpone the case, isn't it? So you anticipate this kind of a problem in a peri-Robin child and keep everything ready. Then it becomes very easy for you to get the airway. So that is okay. The peri-Robin syndrome. Other syndromes are, you said Treacher-Collins.
Yes,
what is this Treacher-Collins syndrome?
So they have cleft palate with micrognathia, parrot beak appearance of the nose, external ear malformations.
There will be a lot of facial anomalies.
Yes.
Hypoplastic maxilla can be there. Then coloboma of the eyes also can be there. Micrognathia will be there. Cleft palate will be there. And as you said, that external ear malformations also will be there. So again, because the micrognathia is there in a Treacher-Collins baby, again, you have the same problems. Plus, you have difficulty as far as mask ventilation also, because the maxilla are hypoplastic. So there will be a lot of leak around your mask. So you may not be able to mask ventilate also. Sometimes there can be macroglassia also there in Treacher-Collins. So in such children, how do you mask ventilate? How do you maintain the airway as soon as you induce?
Introduce any airways.
Yeah, you may have to use a nasopharyngeal airway. You have to keep ready, especially nasopharyngeal airways. So that is about Treacher-Collins. Again, Treacher-Collins can be associated with congenital heart disease. So, okay, other syndromes?
Other syndrome, golden hair syndrome,
Yeah,
Down
golden
syndrome.
hair. What is golden hair?
Mandibular hypoplasia. Mandibular hypoplasia, auricular deformities, ocular abnormalities.
Hemifacial microsomia.
Yeah, hemifacial abnormality will be there. One side of the face is developed, another side of the face is not very well developed, along with maybe micrognathia may be there, and cleft palate also can be there. And invariably, many of these children are mentally retarded. Their milestones also will be very much delayed, so that you have to document. Because later the parents should not claim that it is because of your anesthesia the child has had mental retardation or delayed milestones later. So that is why golden heart syndrome, you should document the milestone also. Okay, then Klippel field. What is Klippel field syndrome? There is fusion of the cervical vertebra. Along with palate, fusion is cervical vertebra because will not be able to manipulate the head and neck. It is fixed like this. So again, extreme difficulty intubation. Endoscopy and intubation. Klippel field is also one of the problems. Okay, then catch 22. Invariably, these are commonly asked by many of the examiners. Just, they know that you may not know, or if you answer, they will get more marks. Because they have anesthetic implications. That's why you have to know about catch 22. You heard about catch 22 or you have not heard about it? Okay, C stands for congenital heart disease. Catch, CATCH. Then A stands for abnormal facies. And T stands for thymic hypoplasia. Thymic hypoplasia. And another C stands for cleft palate. And H stands for hypocalcemia. And usually the 22nd chromosome will have an abnormality. That is why catch 22. Okay. So you know about Vater and Vector. What is
vertebral anomalies, anal atresia.
Very good.
Tracheoesophageal fistula, esophageal atresia, renal anomalies, cardiovascular abnormalities, and limb anomalies.
That is Vector, isn't it? So these are some of the syndromes which you should always know about. So better to know because these can have, these syndromic babies will have more difficulty for you as far as the management of the airway is concerned. Okay, so now once this particular child is posted for either lip surgery or a palate surgery, now how are you going to investigate this child? What investigations you would like to do before taking up? How do you prepare this child? And what are the problems you expect anesthesia concerns as far as the anatomy and physiology of this child?
So investigations will ask for a basic blood hemoglobin, total counts to look for any infections.
So hemoglobin, why hemoglobin is required?
So we need more than 10 grams of hemoglobin.
No, that is okay. Why hemoglobin? You also said that hemoglobin is very important for palate surgery because you expect more blood loss. So then when based on the hemoglobin only, you will be knowing whether the child requires additional blood to be arranged or need not be arranged. So for lip surgery, you don't require any blood arrangement or packed cells to be arranged because the lip surgery is a minor surgery, though it's a very good, important cosmetic surgery, but there'll be hardly any blood loss. Whereas a palate surgery, there can be more bleeding, isn't it? So how do you assess whether the child requires, extra blood to be arranged or packed cells to be arranged or not, based on the hemoglobin?
For 6 months, normal is more than 12 grams per deciliter. So
no, it is nothing to do with whether it is more than 12 or more than 13 or what. So how do you know, or how do you calculate whether the child requires extra arrangement of packed cells or not?
We calculate the maximum allowable blood loss.
That you should tell in the exam. So you always calculate the maximal allowable blood loss based on the hemoglobin or hematocrit. So how do you calculate the maximal allowable blood loss?
So weight of the patient
into
the blood volume, which is 85 ml.
Okay. No, total volume you calculate, isn't it? Usually it's about, in an infant, it is roughly about 80 ml. In a neonate, it can be about 85 ml. So 80 ml per kg body weight. So
Yes.
body weight into 80 ml. Okay.
Into the actual hemoglobin minus the desired hemoglobin.
Divided by actually.
It's the minimal hemoglobin you can
Hemoglobin.
or hematocrit, minimal hematocrit you can allow. Okay. So what is the minimum hemoglobin you can allow?
Up to minimum
8
8
grams.
grams. 8 grams or a hematocrit of 24 or 25. That is a minimal hematocrit or hemoglobin you can allow. Okay. Then divided by
divided
The
by
actual
initial
hemoglobin.
initial hemoglobin.
average of these two.
Yes.
Actual hemoglobin plus minimal hemoglobin you can allow divided by 2. Is it? So that way, usually the amount of blood loss may be about 80 to 100 ml in a palate surgery. So based on your maximal allowable blood loss, if the allowable blood loss is less than 100 ml and you expect more than 100 ml of blood loss, so you may have to arrange for the packed cells, isn't it? At least about 50 ml or 100 ml of packed cells to be arranged for palate surgery. Okay, so okay, hemoglobin, total count, differential count, just to rule out any infection is there or not. Okay, then
Platelets.
okay, that's routinely you can do it. Okay.
Yes, sir.
BTCT.
Bleeding time, clotting time.
Now that hardly helps you because it is not done properly at all.
Echo.
Echo is a must in all,
Identity.
isn't it?
Protocol.
Because many times you may not be able to hear a murmur because of the fast heart rate, and especially these children with a congenital anomaly can have congenital heart disease. So it need not be always the right to left. If it is a right to left, because there will be cyanosis. If it is a left to right, you may not know. And the murmurs you may not be able to hear easily. So that's why an echocardiography is a must just to rule out congenital heart disease. Okay, echocardiography. Anything else?
Serology, blood grouping type.
Yeah, blood group. That is very important, and especially for palate surgery. As I was telling you, you may have to arrange for some amount of 100 ml of the packed cells also. Okay. So now we have done these investigations, and now how do you proceed? Tomorrow the child is being posted. So how do you prepare this child?
And keep NPO as instruct to the mother. I'll keep NPO.
What is the NPO guidelines you will be giving the
So
mother?
for clear fluids or water, 2 hours.
2 hours
For
or 1 hour? No.
1 hour, no.
Yeah,
2
now,
hours.
yeah,
1 hour.
now they have even extended up to 1 hour. Clear fluids can be given. Now, what are these clear fluids? Can you just tell what do you mean by clear fluid?
Water, pulpless juice.
Juice.
Pulpless
Juice.
fruit juices. Okay. Water.
Water.
Water can be. Suppose I have mixed sugar with water. Is it clear fluid?
Clear
Yes.
only, sir.
Clear fluid only, because
Clear
many times only water the child may not drink. If
black coffee, black tea.
yeah, black coffee, black tea, all these are clear fluids. So you should, because unless you know what is a clear fluid, you'll not be able to tell the mother what she should feed. Because many times if you just say you give these fluids, she may give even milk.
Yes.
Milk is a clear fluid or not a clear fluid?
Not a clear.
Why milk is not a clear fluid?
Contained lactose.
Why do you think that milk may not be thought of as a clear fluid? Because it becomes a solid in the stomach. In reaction to the acid in the stomach, it solidifies. So any solid cannot be a clear fluid, isn't it? So that is why you have to consider it as a solid, and that is why all the milk products to be given 6 hours before. Mother's milk
4 hours.
4 hours. Why mother's milk can be given 4 hours early? Because it gets digested faster and then it moves out of the stomach. So whereas the other than the mother's milk, other milk products, they may take longer time to get digested. That is why 6 hours for the other milk products and even formula feeds.
Formula feeds are
For
6
6
hours.
hours.
The children
6
will be
hours.
on formula feeds again. That 6 hours again. Okay. So and water and clear fluid still 1 hour you can give.
Yeah.
What is the advantage of giving till 1 hour of clear fluids?
We avoid hypoglycemia. Child
Avoid
hypoglycemia.
hypoglycemia provided you give sugary drinks. Okay. Then
The volume status of the baby is good.
euvolumic status will be maintained. Very good. Then
We don't want a child to be hunger, like
a child will not cry,
child will not cry.
isn't it? So child usually will cry because of when it becomes hungry only it cries, especially the neonates, infants and all. So once it is fed something, so it becomes very quiet. So when the child is not crying, the mother's anxiety also will be very less, isn't it? So that is the reason why the multiple advantages of giving clear fluid still 1 hour. Nowadays, that is why the guidelines, especially the European guidelines, the American guidelines, they have considered till 1 hour you can feed these children with clear fluids. Okay. So NPO guidelines you'll be talking about. Then what?
And we have to give the pre-medications, like
Again, consent. You don't want to
get a consent.
Yeah, informed consent. You always think about these two things when you visit the patient, any patient for that matter, on the previous evening. So one is the NPO instructions, and the other thing is taking an informed consent. So I will have to tell the mother also about, and sometimes you may have to even tell the mother that you may ship the baby with an endotracheal tube in situ, especially after palate surgeries. Especially if there is a lot of edema that is there inside after the surgery, you will not extubate, isn't it? So that has to be informed to the mother beforehand only. So that is another instruction you will be giving and taking an informed consent. Okay. Then you said about the pre-medication. When with adult patients, you will have to pre-medicate the previous night itself. But do you pre-medicate on the previous night for a child? You say, not required.
Not record, sir. Inside.
Child will not know that tomorrow is a surgery.
Sir.
Small child.
Yes, sir.
So, okay. So next day you would like to pre-medicate. What age children require pre-medication?
More than 6 months of age.
Yeah, why more than 6 months of age they may
That
require?
time only
Separation anxiety.
parental separation anxiety.
Parental separation anxiety. They'll not allow to be separated from their mother, especially. They'll cry. So that is why usually less than 6 months they may not require. They may not have so much of attachment, so that easily you can separate. But later, parental separation anxiety will be there. Okay, suppose if this child is say posted for palate surgery in about 18 months or 16 months. So what pre-medication you would have given? This particular child may not require just 6 months, but otherwise, what are the pre-medications that are usually given in pediatric age group?
Usually we are using promethazine, sir, 0.5 to 1 milligram per kg, sir, promethazine.
What are the advantages of promethazine?
It have an antihistaminic effect, anticholinergic effect, and a sedative, and as well as
Anti-sialagogue?
Anti-sialagogue
also. Will it produce anxiolysis also?
Yes,
Yes,
anxiolysis.
It is the most important. First thing you should have said that. Sedate, they'll produce sedation and anxiolysis. Okay. So anxiolysis is there, anti-sialagogue effect, anticholinergic effect, anti-emetic also, and antihistaminic also. So multiple advantages. But what is the disadvantage with promethazine? Does it produce analgesia?
No, sir. No, sir.
It won't produce
No,
analgesia.
sir. No, sir.
It can, if other analgesics are not given, it can produce some amount of anti-analgesia. It may decrease the pain threshold. So that is one problem with promethazine. Otherwise, it's a very good
Nice.
as a pre-medicant. What other pre-medicants you could have used?
Sir, non-sedative hypnotic oral tricofast 80 to 100 milligram per kg.
Triclofas. Yes, triclofas, that is chloral hydrate, phosphorylated chloral hydrate, can go for 25 milligram per kg body weight. Okay, in babies. Okay, chloral hydrate is also almost similar effects as far as promethazine is concerned with chloral hydrate also, and produces a better sedation. Chloral hydrate. Okay. Any other?
Nasal most commonly oral midazolam, sir. 1 milligram.
Oral midazolam, isn't it?
Yes, sir.
So what is the dose of oral midazolam?
1 milligram per kg. 0.5.
0.5 milligram per kg. 1 milligram slightly higher. Usually 0.5, 0.2 to 0.5 milligram.
Per kg.
Can it be given through the nasal spray also?
Yes, sir.
Yeah, nasal spray.
Yes, sir. Yes, sir.
Yeah.
0.2 to 0.3 mg per kg.
Along with an atomizer, it comes just about 0.2 to 0.5
0.3
milligram per kg body weight. So it is easy, isn't it? You just spray into the nostril. So that is sufficient to produce quite a bit of sedation in this child. Okay. Any other pre-medicant you can use?
Nasal dexmet, sir. 2 mics per kg.
Again, spray. 2 mics per kg body weight of dexmedetomidine is one of the, again, or clonidine 4 mics per kg body weight. Or, all things may not produce sufficient analgesia. So if you want associated analgesia also,
Ketamine.
you can give ketamine, oral ketamine. What is the dose of oral ketamine?
3 to
6 milligram per kg.
Yeah, 3 to 5 milligram per kg body weight. Oral ketamine you can definitely give. Nasal ketamine also you can give with the same dose.
3 to 6 milligram.
Recently, there are many articles wherein they have nebulized ketamine and dexmedetomidine together.
Okay.
Dexmedetomidine 2 mics per kg body weight and ketamine again 3 milligrams per kg body weight nebulization. Just about 15-20 minutes before, and produces beautiful effect as far as the premedication is concerned. Especially, you know that ketamine produces tachycardia and dexmedetomidine produces bradycardia. So together, the heart rate is very well maintained. And ketamine produces increased salivation. Dexmedetomidine decreases
salivation.
Again the blood pressure effects. So there are multiple advantages in combination of dexmedetomidine with ketamine. So these are few of the things which you should better know about as far as the pre-medication is concerned. Okay, now what are the concerns you have in managing pediatric patients? So all the changes, anatomical and physiological changes compared to adult, you will have a lot of problems because of that, isn't it? So you have to have a lot of concerns regarding this. Can you just tell about all these changes, anatomical and physiological changes in an infant, which you have to be, very carefully you have to manage because of these anatomical and physiological changes, and a lot of anesthesia concerns are there because of these changes. So can you just enumerate, you can even describe all these changes?
Respiratory, they're obligate nasal breathers.
Yeah, you can start with the upper airway. Okay.
Okay, sir. Obligate nasal breathers.
Why they are nasal breathers?
Large tongue, so
No. Why, nature has made them to be more of nasal breathing, obligatory nasal breathers. See, simultaneously they can feed and breathe, isn't it? So one. Second thing is, they have a increased closing capacity. That will come to that. So when they breathe through the nose will produce, because nostrils are smaller diameter, isn't it? So they produce slightly more resistance. They produce some amount of CPAP, so that the collapse of the airways and alveoli is prevented. So that is the reason why they are. So why should you know that they are obligatory nasal breathers?
While introducing the Rayleigh tube or anything, we will not damage the mucosa or anything, sir. It's
Nothing to do with the, when you introduce a nasogastric tube, you are obstructing the particular nostril, isn't it? So as far as possible, you should avoid anything to be placed through the nostrils.
nostril.
Because once you are obstructing one of the nostrils, the child may not be able to breathe easily through the other nostril. That is one important thing. So try to avoid, things that are passed through the nasal cavity. Another very important thing in these children with cleft lip palate and all, because they have got repeated respiratory infection, there can be a lot of nasal crusts, which may be blocking. So it is very important that you try to clean these nasal crusts before starting your anesthesia, so that you clear the nostrils, you make them more patent. So that is why this is okay. Okay, one is obligatory nasal breathers. Okay, what are
Have a
the
relatively large tongue.
no? Before that, the head itself.
Large head, sir.
large occiput.
Large.
Yeah, you should start with a large head when compared to the body, and also there is a large occiput. So what is the implication of this?
That's a natural.
Head is always flexed in position, sir, because of
Yeah,
that.
it is,
Natural sniffing
as
position.
such, it is flexed. So you need not have to keep a
Like,
pillow under
pillow
under
under the head.
head or occiput, because in adults you will be keeping a pillow under the occiput, isn't it? So that is one thing. Okay, you may have to keep a folded towel or cloth under the shoulders.
Shoulders.
Slightly elevate the
shoulder
shoulders,
base of the head.
isn't it? So that you can bring the tragus in line with the sternum. That it becomes easy for you to introduce your laryngoscope. So what is the other problem with the large head? Other than, automatic flexion will be there. What is the other problem? Because large head is there means large surface area. Large surface area getting exposed means
Hypothermia.
So you should always cover the head throughout the procedure. That is very important. Of course, in this cleft lip palate, this head and neck surgery, so automatically the drapes are covering the head and neck. But otherwise, if they are coming for other surgeries like hernia and all, so you have to cover, because there will be more loss of heat from the body, from the head area, because large surface area is exposed. So that is another important thing. Okay, what about the facial features? Features of the face. Are they very well developed like adults or not very well developed? Facial features are not very well developed.
Yes,
like in adult patients. They are in the process of development. So because of this, what is the problem? Can you use an anatomical face mask?
No.
You will not be able to use it because is made for adult patients where the facial contours are very well developed. Here, facial contours are not very well developed. So you cannot use an adult
anatomical face.
So what kind of a face mask you have to use?
Pediatric transplant face mask or RBS face mask.
Don't say RBS. RBS is only for random blood sugars.
Rendell-Baker-Sokes mask.
Yeah, Rendell-Baker-Sokes mask. So what is the advantage of a Rendell-Baker-Sokes mask?
They have a less dead space compared to that.
Why there is less dead space with the Rendell-Baker-Sokes mask?
It fits the
why the dead space is less? Minimal dead space it has got. Why minimal dead space?
Because the material is made up of silicone and it fits.
No, it can be even black rubber.
Black.
It need not be silicone. And that is nothing to do with the dead space. The dead space is what is there inside the mask. Now, because it doesn't have a cushion at the periphery, like anatomical face mask, you have a periphery, it is cushion, isn't it?
Cushion,
So
yes, sir.
it produces
Elevates.
elevation, so that more space is there between the mask and then the actual airway.
Okay.
So that produces increased amount of dead space. So with a Randall-Baker-Sosek mask, you can even push it down. You can compress it so that you can bring the fresh gas flow very close to the airway. So that's how you can definitely reduce the dead space.
Dead
So
space.
the most important thing, and it is triangular in face, in shape. So it can fit into the ill-contoured face of a neonatal and infant. So that is why one of the specially designed mask is used. In older children, what kind of mask you will use? Any special type of masks in older children? This one they can accept. Now they are called as scented masks.
Scented, okay.
Perfumed masks. So different flowers scents are applied for these masks so that the child is made to smell these. The child can take a particular type of mask, particular type of scented mask. So that is one of the things, and majority of them are transparent masks. So what is the advantage of mask being transparent?
We can look at the fogging.
Okay.
And it won't be claustrophobic for the patient.
Yeah, that is more important, isn't it? The child can accept a transparent mask when compared to an opaque mask. And other thing is, if there is any vomiting or anything, you can easily see through it. So that is one other thing. Okay, now coming to the oral cavity.
Large tongue. Large tongue.
Large tongue in relation to what?
In relation to the face.
In relation to oral cavity.
In relation to the oral cavity.
So what is this basic principle of classification of the difficult airway based on the relative size of the tongue and oral cavity? Correct. Malampati classification, isn't it? Malampati classified based on the size of the tongue in relation to the size of the oral cavity. Well, tongue size is large when compared to the oral cavity. You will not be able to visualize the pharyngeal structures. And that way he says that you will not be able to visualize the laryngeal structures when you do a laryngoscopy, because if there is a large tongue, small oral cavity, there is not sufficient space for you to push the tongue away from visualization of the larynx, isn't it? So that is a basic idea. So here there is a large tongue when in relation to the oral cavity. What is the problem?
Difficult in...
Yeah, it is a difficult airway. All pediatric airways are considered as difficult airway. Already we discussed difficult mask ventilation is always there. And another thing is difficult laryngoscopy also can be there. So, okay. Now, other thing is, there are teeth will not be there. Edentulous, isn't it? Why should you know about this? In adults, if they are edentulous, there is a problem of buccal pad of fat. But in children, there is enough buccal pad of fat. That is not a problem as far as holding a mask is concerned. But what is the other problem?
Sir, intubation.
Pardon? The tissues are very friable of the upper alveolus or even the lower alveolus. So if you are not gentle in your laryngoscopy, you may produce injury that may start bleeding and you may not be able to see anything inside. That is why because there are edentulous, you have to be extremely gentle when you are introducing your laryngoscope and doing a laryngoscope. So that is the idea. Okay. Now going inside the oral cavity, you will find the epiglottis.
Floppy oval.
Floppy
omega shaped epiglottis.
Large floppy omega shaped epiglottis. Why it should be large floppy omega shaped? Why nature has made like that?
Larynxes and the level of seat.
Pardon?
To prevent aspiration.
Yes, to prevent aspiration while it's feeding. Because the child is breathing and feeding. So it separates the oropharynx from the nasopharynx totally, this large epiglottis, so that the child can breathe also and can swallow the milk that is it is feeding. That is why usually it will be a large omega shaped, floppy, whereas in adults it is leaf-like, small leaf-like. So what is again the anesthetic implication with this?
So we have to lift it with the epiglottis when lift it during a laryngoscope. We have to lift it along with the epiglottis for the
Lift along with
visualization.
no, lift the epiglottis with your blade, isn't it?
Yes, sir. Yes, sir.
Tip of the blade. Normally, in adult patients, what is the method of your laryngoscope?
We introduce the blade into the vallicula and lift the vallicula to visualize.
And then you lift upwards and forwards,
Yes.
so that you are actually stretching the glossoepiglottic and hyoepiglottic ligaments. So the epiglottis automatically comes up so that you can visualize the glottic opening. But here, when you do that, still you may not be able to lift the epiglottis because it is so large. So you have to go in front of the epiglottis and also take the epiglottis along with the tip of the blade. So what kind of laryngoscopes you will have to use?
Miller's blade. Straight blade.
Braided laryngoscopes. Miller's or Wisconsin straight blade laryngoscopes are ideal to be used in this pediatric. So that is the idea of knowing about the large epiglottis. Okay. Then afterwards is the glottic opening. So especially the location of the larynx or site of the larynx. So in adults, where exactly is the position of the larynx, and in
C4, C5.
C4, C3, C4.
No, in adults it is 4, 5, 6. Bodies are the cervical 4, 5, 6. Whereas in full-term infant neonate,
C2.
C3, 4.
C4.
C3, 4, 5. So whereas in preterm neonate,
C2, C3.
C2, 3, 4. So that is why, in a small neonate and also infant, so they are more anteriorly placed, the larynx. You may not be able to visualize the larynx easily when you are doing the laryngoscopy. Even when you use your straight bladed laryngoscope also, many times it will be extremely difficult to visualize the larynx because larynx will be slightly more anteriorly placed. So your vision will be in the straight line, isn't it? So you'll be looking at the esophagus when you do. So what manipulation you have to do now in order to visualize glottis?
Burke maneuver, sir.
Either Burke maneuver or external laryngeal manipulation. It is called as, nowadays it is called as external laryngeal manipulation. That is what you have to do it. And if you're all alone, how do you do the laryngoscopy? Because of this. How do you manipulate the larynx and also do the laryngoscopy together?
Use a little finger to manipulate the larynx.
So where do you hold the laryngoscope? Normally you hold the handle, isn't it? You balance at the handle. Whereas for a small child, where you have to hold so that your little finger can be very close to the thyroid cartilage, wherein you can manipulate the thyroid cartilage by pressing.
The blade and the blade and the angle of the
where actually the blade and then the handle meet. That is almost like a web. There you will be holding, much proximally you will be holding. So that is one of the changes you have to make when you are all alone. Otherwise, when you have an assistant, so who will do the external laryngeal manipulation and who is going to intubate the endotracheal tube?
So we do the external laryngeal maneuver and we have somebody else to.
The person who is doing the laryngoscopy also does the external laryngeal manipulation. And he'll be, clearly seeing the larynx, and the other person has to hold the endotracheal tube and then pass the endoscopy. That is the best method of intubating an infant. Okay, so that is about the larynx. And again, another important thing is what is the shape of the larynx is supposed to be in pediatric age group. It is funnel shaped. Now they have found even in adults also it is funnel shaped. Otherwise, it was said that adults have got a cylindrical one. So because of this funnel shape, which is the narrowest part of the larynx?
Cricoid region.
Cricoid cartilage is the narrowest. So why should you know that cricoid cartilage will at that level is the narrowest part of the larynx?
Because tube size for the
Tube, cuffless tube only we are using because of that narrowest part.
Because for that only we were thinking of using a cuffless tube. So why a cuffless tube?
so it goes inside and fits in the narrowest part without the cuff. So minimal tissue damage. Yes.
Because if we are giving along with the cuffed tube, it may cause
Edema.
tissue necrosis or because edema will produce.
No. So adults also we are using a cuffless with cuff tube.
Because
not a cuffless tube. Why?
Because it's a circular shaped, sir, that cricoid region.
Edema covers more than half of
You need
the.
to realize the cuff that is present in an adult endotracheal tube, you must have seen. It is not very close to the bevel. It is much proximal to the bevel. If that is the type of tube with a cuff is present in the pediatrics also, because the length of the trachea. What is the length of the trachea as such?
12 to 14.
12 to 15 centimeters. In infants?
4 to 5
centimeters. It is 5
centimeters. 5 centimeters.
So if you are using a regular cuffed endotracheal tube, the cuff will, encroach into the cricoid cartilage. It should not be entering into the larynx. Actually, the cuff should be distal to the larynx when you introduce the tube. But here, because the cuff is more proximal as far as the bevel is concerned, in an adult type of, cuffed endotracheal tubes, what also are there in many of the pediatric cuff tubes. So that may directly encroach upon the cricoid cartilage and that can produce pressures. So that, the postoperatively the child can develop the subglottic stenosis. It is called as a subglottic edema, and there will be a lot of resistance for breathing by the child. So the child even may go for respiratory distress because of this subglottic edema. That is why, majority of the times we were using a tube without a cuff. So, but what are the problems if you are using a tube without a cuff?
Mild leak is always.
One is leak. Okay. Yeah. So that, your tidal volume, whatever the tidal volume you are keeping on the ventilator is not being delivered to the child's lungs. That is one. Lot of leak. Okay. What is the second problem?
Accidentally entered endobronchial or accidental extubation, maybe pulling out.
Yeah, it is loosely fitted there, so it may come out also. Especially the upper airway surgeries, especially head and neck surgeries. That is another thing. Proper fixation will not be there. Okay, second problem. What is the third problem?
Risk of aspiration is always
risk of aspiration, because there is space around the tube. So risk of aspiration. Okay, what is one more problem? So do you usually monitor ETCO2 in pediatrics?
Yes. Yes.
So is it reliable if there is a lot of leak around? No. Yeah, it will not be reliable. Your ETCO2 will not be reliable. Okay. What is one more problem? What is the fifth problem if you are using a cuffless tube? Because these are all exam questions, so that's why.
Positive pressure. Continuous positive pressure.
No, you can apply positive pressure, though there will be leak. Now, because what is the shape of the endotracheal tube? It is curved like this.
Yes, sir.
So when you're placing without a cuff, so the tip will be touching the upper surface of the inner surface of the trachea.
Yes, sir.
Isn't it? So either the bevel may get blocked because it is abutting against the inner surface of the anterior part of the trachea. One. The second problem is a continuous friction intraoperatively. It can lead to postoperative sore throat for the child. Suppose if you are using a cuffed endotracheal tube, where will be the position of the tip? Yeah, it will be centrally placed, isn't it?
Yes, sir.
It will be centrally placed. Because cuff is there and it gets inflated.
On both sides.
The tube tip will be in the middle of the trachea. It will not be abutting against the anterior of the trachea. So that again it produces a decrease in the chances of child going in for postoperative sore throat. But you cannot have your ordinary cuffed endotracheal tube. You have to have a specially designed endotracheal tube, cuffed endotracheal. What is this called as?
Sir,
Micro.
Designed cuffed endotracheal tube you require.
yes, sir. Like
What is
RA tube, sir.
RA tubes are other than those things. We'll also discuss about RA tubes and Oxford tubes and all. Regularly, for example, a child comes
Low pressure, high volume. High volume, low pressure cuff.
Micro cuff.
Micro
Microlaryngeal.
micro cuffed endotracheal tubes. What is the difference between the regular cuffed endotracheal tubes and micro cuffed endotracheal tubes?
So micro cuff is placed near to the bevel, so the cuff is placed
more towards the
just
bevel, so that it will not extend into the cricoid cartilage. Okay, that is one thing. Okay, what is the shape when it is inflated? Micro cuffed endotracheal. It produces a rectangular shape, unlike a globular shape of the regular endotracheal tube cuff. It will be globular like this. So this is more of rectangular. If it is more rectangular, what is the advantage?
fits into the cricoid, less mucosal edema.
No.
Less aspirations.
No, it will be in the trachea only because it is more close to the bevel. So it will be in the trachea. So being rectangular rather than globular, what is the advantage? What is the surface area that comes in contact with the inner wall of the trachea? Is it more or less?
Lesser.
Being rectangular.
Being rectangular, it is more, sir. The entire
More.
area.
Yeah.
Surface area.
What is the advantage?
Less aspirations.
No, nothing to do with aspiration.
Equal pressure, constant
The
pressure is
exerted per a unit area is much less. Because now, it is coming in contact with more surface area of the trachea. So the pressure exerted at a particular unit area is much less because the pressure gets distributed. So that is how, the post-operative problems of sore throat is much reduced with the microcuffed endotracheal tube. Another thing is, what is the material with which this is made of? Microcuffed endotracheal. Cuff is made of what?
PVC.
The regular endotracheal tube cuff is also made of PVC, but here it is made of polyurethane. Polyurethane is more inert, so that its reaction with the mucosa is much less. So that is why nowadays we are also using microcuffed endotracheal tubes for long surgeries, especially the child is posted for long surgeries. Definitely microcuffed endotracheal tube will help because the leaks are prevented, aspiration is prevented, then postoperative sore throat is much less, and you can rely on the ETCO2 continuously. So that is how we will have to use this kind of. We'll come to when I'll ask you what kind of a particular endotracheal tube you will be using for this particular child. We'll discuss that later. This is only anatomical changes compared to adult anatomy of the upper airway and how do you modify. Okay. So another thing is now the length of the trachea you said is very short. So what is the implication?
So the intubation, it goes endobronchial. It might go endobronchial.
Yeah, chances of it becoming endobronchial is very high, isn't it? Because the length of the trachea is very short. So slight flexion of the head of the child, it goes into one of the bronchi. And what is the problem if endobronchial intubation occurs?
It's ventilated.
Now what happens if there is intraoperatively suddenly the tube
airway pressure
to one of the bronchus?
Airway pressure is more desaturation, a tight bag.
More of one lung ventilation, isn't it?
One lung ventilation.
So it becomes one lung ventilation. If one lung is ventilated, the whole lung is a shunt becomes. So there will be a lot of desaturation. One of the most common causes of hypoxia intraoperatively in a pediatric age patient is endobronchial intubation. So that is one thing you should always realize. And if there is desaturation, what will happen to the heart rate in a child?
Bradycardia.
Yeah, there will be bradycardia. And most common cause of bradycardia is
It's
endobronchial intubation.
Intubation.
Most common cause of bradycardia is endobronchial intubation. Don't try to jump to give atropine. So it is actually because of desaturation, and try to pull out the tube by 1 centimeter, everything will become fine. So that you should always realize. That is the idea of anesthetic implication of short trachea. Okay, what about the carina?
More horizontal.
Carina is actually divides into the right bronchus.
Right bronchus and left bronchus.
Yeah, with what is the angle?
One reduce.
Now, in the adults, what is the angle of right and left bronchus?
So, right is more obtuse.
Now, right is 25 degrees, left is 45 degrees in adult patients. So that is why, the right bronchus is in line with the trachea. So if at all endobronchial tube migration occur, it is always into the right bronchus. It is always into the right bronchus. Whereas in a infant and neonates, it is 55 degrees. It is equal, both the right bronchus and left bronchus. So the tube can migrate into either right bronchus or left bronchus. So that is another very important thing you should know about. Okay, what about the lower respiratory system? What are the differences compared to adult? What about the number of alveoli?
Alveoli comparatively less when compared to others.
How many in the adult and how many in the pediatric, especially neonate and infants?
15 to 30 millions.
100 million in
100
pediatric,
millions.
300 million in adults. Okay, so less number of alveoli. Okay. And lung is less matured. Okay. That's another thing. What about the diaphragm?
Diaphragm is high. Diaphragm is placed in a higher diaphragm.
The angle with the origin of crural fibers of the diaphragm will be in an acute angle, so it may not be able to contract well. That is one. Okay, what are the type of fibers in the diaphragm?
Type 1 and type 2 fibers.
What kind of fibers will be there more or less in case of...
Type 1 will be more.
Type 1 will be less or more in pediatrics?
It will be less in pediatrics.
Yeah, less in pediatrics. What are these type 1 fibers?
Slow fibers which...
Slow and
long
fatigue resistant fibers.
Yeah, they are fatigue resistant. They require, for normal respiration, they are required, isn't type 1. So in adults, what is the percentage? And in pediatrics, what is the percentage?
30%.
In adults, what is the percentage of this type 1 fibers?
55%.
More than 60%. In full-term infant and neonate, it is about 20%. In preterm neonate, it can be even less than 15%. It can be around 10%. That is why you must have seen these preterm neonates go for repeated spells of apnea, isn't it? So they get exhausted. They just stop breathing because their type 1 fibers are very minimal. So even neonates, the full-term neonates, because the type 1 fibers are less, so they may not be able to increase their tidal volume, isn't it? So their alveolar ventilation will depend on mainly than the tidal volume. Okay, so that is another important thing about the type 1 fibers being less in infants and neonates as far as the diaphragm and intercostal muscles. Both type 1 fibers will be less. Okay, what about the respiratory mechanics?
It's a piston type.
Piston movements, not the adult pump handle movement will not be present. Piston type of movement will be present.
Okay, respiratory mechanics means usually the FRC, the closing capacity.
FRC is reduced, sir. 30 ml per kg only.
30 ml. Adults is how much?
35 ml.
Yeah, 35 ml. So FRC is decreased. Okay. What
capacity.
about the closing capacity?
It's higher, sir, compared to the
capacity is higher. So because of higher closing capacity, what is the problem?
Child more prone for atelectasis.
Yeah. So airway closure can occur. Rapid airway closure can occur. So rapid desaturation can occur. So another very important thing is the alveolar ventilation. What is
Alveolar
alveolar ventilation in
alveolar ventilation.
pediatrics?
Pediatrics. Alveolar ventilation is
How many ml in adults and how many ml in neonates and infants? Now, these are the questions you'll be asked. Not that everything is asked. Suddenly, they may start asking few questions on respiratory system changes.
4 to
And
5 ml in pediatric.
pardon?
4 to 5 ml in pediatric.
Alveolar ventilation. I'm not asking about tidal volume. Alveolar ventilation in adults is roughly 130 ml, sorry, 65 ml per kg body weight. In neonates, it is 130 ml. It is twice the alveolar ventilation of an adult. So high alveolar ventilation, low FRC. That is a characteristic of infants and neonates. Why there has to be a high alveolar ventilation? Why alveolar ventilation should be high?
because
Only less is getting oxygen. Okay.
because of the immature.
No. You should know about the oxygen consumption and carbon dioxide production. What is oxygen consumption and carbon dioxide production in a
Infants, oxygen consumption is high.
Higher, sir. Oxygen consumption is higher compared to adult.
no, how much? No, you should know.
6.5 ml per kg per minute, sir.
It's usually 7 ml
7 ml.
in neonate and infant. In adults,
3.5 ml per kg per minute.
so oxygen consumption or oxygen requirement is twice the adult requirement. Okay, what about the carbon dioxide production?
Production is
35 ml.
more, sir.
30.
Adult, it is 3 ml per kg body weight, and in neonate and infants, it is 6 ml per kg. Again, carbon dioxide, because high metabolic rate.
Yes,
They are
high
growing
metabolic.
rapidly, very fast. Their metabolic rate is very high. So their carbon dioxide production is 6 ml. And ventilation has to be adequate to excrete this carbon dioxide, isn't it? So because their carbon dioxide production is twice the adult carbon dioxide production, their alveolar ventilation has to be twice.
Nice.
So that the carbon dioxide PSCO2 can be maintained. That is why their alveolar ventilation is twice the adult, and their oxygen consumption is twice the adult. They have got a small FRC. All these are, what are the implications because of all these?
Child is more prone for desaturation.
One is child is more prone for desaturation because the small FRC, high oxygen requirement. Okay, what is the other implication? How this alveolar ventilation is maintained?
Rate.
Because of a
Cannot increase tidal volume, isn't it? What is the tidal volume? Infant and tidal volume of an adult?
6 ml per kg.
7 ml, isn't it?
7
ml.
7 ml. Baby is also 7 ml. So tidal volume is not changed. But since they have to have twice the adult alveolar ventilation, so this is managed by respiratory rate. So alveolar ventilation is rate dependent alveolar ventilation. So why should you know about this? You know that it's a rate dependent alveolar ventilation.
Because increasing the tidal volume or decreasing the tidal volume during hypercapnia won't help. We need to increase the rate.
No, there won't be any tidal volume cannot be increased, and you cannot also increase the tidal volume when you are ventilating. You have to keep the same tidal volume as 7 ml per kg body weight. What you have to increase is
respiratory rate.
Adults, you keep a respiratory rate of 12 to 15, whereas the infants and neonates, you may have to keep 25 to 30.
30, yes, sir.
So that is the one important thing. Second important thing is, suppose if you give opioids for these children, they're extremely sensitive to opioids. So opioids always reduce the respiratory rate rather than the tidal volume. So once the respiratory rate comes down, so alveolar ventilation gets affected. So these children will have hypercarbia, hypoxia, hypercarbia. That is the another reason you should be very careful in unnecessarily giving opioids as analgesics for these neonates. Okay, what is the third implication? Because alveolar ventilation is very high, FRC is very small. I'll give you a clue. We want to, take the child induced with inhalation anesthetic agents.
It's prone for desaturation, sir. Quick
Not
desaturation.
desaturation. I want to induce a child and I want to induce an adult with inhalation induction. Is there any difference?
Higher concentration.
Because there's high alveolar ventilation, increased alveolar ventilation, small FRC.
Rapid induction and rapid elimination will be there.
Rapid induction can occur. So rapidly, as you said, that the concentration of the inhalation anesthetic agent can build up very fast and very high. And especially when you're using an inhalation anesthetic agent like halothane. So it can produce quite a bit of myocardial depression because it's so extremely potent, and also it has got a lot of depressive effect over the myocardium. So that is another reason why you should know about this. So there can be very rapidly they can get induced. Okay, so these are all some of the implications of knowing about the respiratory mechanics. So increased oxygen requirement, increased carbon dioxide production, increased alveolar ventilation, decreased FRC, high closing capacity, isn't it? So the tidal volume cannot be increased, and respiratory rate dependent alveolar ventilation. And another very important thing is about the compliance of the lung and then the compliance of the chest wall. What happens? What is the compliance of the lung in these total lung?
Reduced. It's reduced, sir.
Yeah, lung compliance is because immature lung. So lung compliance is low, whereas chest wall compliance
It's higher.
is high. Chest wall will not be producing support to the lungs. So there is another reason why they cannot increase their tidal volume. There is not much of a support from the chest wall because the chest wall compliance is very high, lung compliance is very low. So these are all very important things to know about and their anesthetic implications. Okay, coming to the cardiovascular system.
Cardiovascular, there is a less contractile tissue, sir, when compared to adults. So there is a stroke volume will be reduced compared to others. So it is a rate dependent only, sir.
So stroke volume cannot be increased, not it is reduced.
It's not be increased.
Now, what about the cardiac output in these children? Is it cardiac output is high or low in pediatric age group?
It's a high.
Per kg body weight, again, it is twice the cardiac output of an adult because the requirement is high. Because metabolic rate is high. So the cardiac output has to meet the metabolic rate of the tissues. So it has to be high. But unfortunately, the myocardial contractile fibers are less. So naturally, it cannot increase its stroke volume. So the cardiac output is again rate dependent. That is why when you are resuscitating these neonates and infants, if the rate falls down to less than 60, you may have to start external cardiac compression. Whereas in adults, if it is 60, you don't start your external cardiac compression because many of the adults can have only 60 or 50 heart rate, isn't it? So that is another very important thing about the heart rate and the myocardial contractile fibers. And you see another important thing about the myocardial contractility is, are they more prone for depressing effects of the IV anesthetic agents and inhalation anesthetic agents?
Yes,
the myocardium?
Yes, sir. Myocardial depression.
Why it's more prone for myocardial depression, the pediatric heart?
The fibers, the fibers are less.
No, fibers are less, it's okay. That is one of the reasons. What is the other main reason? Because of the inhalation anesthetic agents, even sevoflurane can produce quite a bit of myocardial depression.
Because normally pediatrics is a parasympathetic predominance compared to that.
That is nothing to do with the myocardial depression as such. The parasympathetic, sympathetic as far as your heart rate is concerned. See,
autonomic systems.
So one thing you should also know about is, the calcium source for the myocardial contractility or the myocardial fiber to contract is not from the sarcoplasmic reticulum, because the sarcoplasmic reticulum inside the myocardial fiber will not be able to store much of the calcium. So the calcium, the external calcium, that is from the extracellular fluid, has to enter the myocardial fiber to get attached to the troponin and then release the actin filaments so that contractility occurs. Because it is dependent on the extracellular calcium to move inside, and most of our inhalation anesthetic agents prevent this extracellular movement of calcium into the cell. So that's how, because they cannot store much of the calcium into the sarcoplasmic reticulum or endoplasmic reticulum. So that is the reason why their myocardium is highly prone for myocardial depression. That is another thing which you should know about. And halothane can really produce severe depression. And especially if you start ventilating, holding a mask with halothane, these children can go for arrest. So that is one more important thing you should know about. Okay, that is about the cardiovascular system. And another thing you said that the sympathetic is less developed and parasympathetic is slightly more developed. So the response to hypoxia and hypercarbia is more of bradycardia.
Bradycardia.
Yeah, that already we have discussed, isn't it? So that is why any bradycardia, you should always look for hypoxia and don't try to give atropine. If you just correct hypoxia, the heart rate gets corrected. One. Second thing is when you are doing a laryngoscopy, in adults, what is the response?
Hypertension, tachycardia.
Tachycardia is the response. So in these neonates, when you are manipulating the larynx, larynx and pharynx, there is more of bradycardia response. So you should be aware of that, and you should keep always ready atropine in such situations. Okay, so those are the important things as far as cardiovascular system is concerned. Okay, coming to the temperature regulation. What about temperature regulation in pediatrics?
Pediatrics is normally temperature regulation in adult is by shivering and non-shivering mechanism. More of shivering in adult. In adult, but in pediatrics, more of non-shivering mechanism.
Why they cannot shiver?
Because of presence of brown fat.
No. Why they cannot shiver? I was asking. Why not shivering thermogenesis in infants and infants? They don't have enough muscle mass.
Muscle mass.
Yeah, because for shivering, muscles are required to be contracted. They do not have, isn't it? So they mainly depend on non-shivering thermogenesis. What is this non-shivering thermogenesis?
Presence of brown adipose tissue is present in the scapula, mediastinum, and the kidney and everywhere. Once the temperature goes down, it will start increase the metabolism. It has a presence of autonomic supply also. So noradrenaline can release in weight, increase the metabolism, and water consumption will be more. And that time it will produce heat as well as water consumption.
So oxidation of brown fat, isn't it? Why the brown fat is brown? Why it's brown? Otherwise, fat is yellow, isn't it? Why this you call it as a brown fat? Because it contains a lot of mitochondria.
Presence of mitochondria.
Increased mitochondria. And mitochondria are powerhouses. So that is the reason why it can generate a lot of heat energy. But again, for that, oxygen is required. That is one problem, isn't it? Even like in adults, when they shiver, they require a lot of oxygen. Like that, even for thermogenesis, through the oxidation of the brown fat, a lot of oxygen will be consumed by the child. So that is another problem you always think about. So otherwise, why? That is one of the reasons you said that why these children are more prone for hypothermia. What are the other reasons why they are more prone for hypothermia?
The large surface area.
So what about the thermoregulatory center?
It's not developed.
Yeah, it is not matured enough, isn't it? It is an immature thermoregulatory center. So it may not be able to immediately know that there is the temperature is dropping and then take measures to increase the body heat, isn't it? So that is one immature thermoregulatory center. Okay, then
because our anesthesia.
Again, you said that surface area, body surface area is much larger when compared to the body weight. So exposure can produce a lot of body heat loss. Then
Good environment.
Our
Subcutaneous fat
Is
is less.
good insulation is less.
Yes.
So that is why exposure of the skin or the body tissue, there can be a lot of heat loss, isn't it? And then one more thing is they cannot move away from a noxious environment. And for example, if you are pushed into a very cold environment and suddenly you'll come out, you'll not stay there. Isn't it? And plus, already you discussed about non-shivering thermogenesis, which is not enough to produce enough of heat. So these are all the reasons why they are highly prone for hypothermia. So what are the measures you will have to take in order to prevent hypothermia?
Pre-warm the bed, sir. The OT table, pre-warm the OT table. The OT room.
OT environment, isn't it?
Oh, yes, sir.
Environmental temperature is the OT. Normally, in adult patients, what is the OT temperature you keep?
18 degrees.
Usually it is OR temperature, always we say that it is 20 degrees.
20.
Isn't it? In especially in transplant surgeries, in neurosurgeries, you have to reduce further to 16 degrees or 18 degrees. But usually it is about 20 degrees, isn't it? So why you always keep at 20 degrees in adult patients? And in pediatric, what is the temperature you would like to keep?
25 to 24.
Yeah, why 25 degrees in pediatrics? For that, you have to talk about critical temperature and neutral temperature as far as the environmental temperature is concerned. What is this critical temperature?
What is
the definition of critical temperature? It is that environmental temperature below which an unanesthetic, unclothed person will not be able to maintain a normal core temperature. It is that environmental temperature below which an unanesthetic and unclothed person will not be able to maintain the body core temperature. And in adults, what is this critical temperature? How much? It is 1 degree centigrade. One degree.
Yes, sir.
So anything above 1 degree, he can definitely shiver and he can definitely maintain his core temperature. Below 1 degree, like 0 or minus, he may not be able to. So whereas in a full-term neonate, what is this? How much is the critical temperature? It is 23 degrees critical temperature. And in a preterm neonate, what is the critical temperature?
26.
28 degrees. 28 degrees is the critical temperature. So you have to maintain an environmental temperature above this critical temperature for infants and neonates, so that the core temperature will not drop so much. That is one thing. Another thing I was telling you is about the neutral temperature. What is the definition of neutral temperature?
Temperature is the body's temperature and the environmental temperature.
No, neutral temperature is that environmental temperature. So above which there is the least oxygen requirement to maintain the core temperature. So oxygen requirement, because there is no shivering, there is no non-shivering thermogenesis, oxygen requirement will be minimal. So it is that environmental temperature where the oxygen requirement of the body will be minimal. That is called as a neutral temperature. How much is the neutral temperature in adult patients? It is 23 degrees.
23.
In full-term neonate, what is the critical neutral temperature?
25 degrees.
It is 32 degrees. And in a premature neonate, it is 34 degrees.
Okay.
That is why you must have seen in the incubator, we'll maintain a higher temperature, more than 34.
32.
We'll maintain about 36 or 37 to keep the neutral temperature around the premature neonate. Even for a full-term neonate, as soon as it is born, many times we keep that in the trolley where it is around that the heat is generated, isn't it? Thermostatically controlled temperature, increase in temperature, we always keep the baby warm. So usually we keep about 34 to 35 degrees. So in order to see that the oxygen requirement will not increase. So when you want to maintain a OT temperature, you maintain the OT temperature between the critical temperature and neutral temperature. Of course, I should always maintain it near to the neutral temperature. But why not maintain 32 degrees, which is the neutral temperature?
Too hot to work.
Huh?
Too hot for the...
Yeah, isn't it? You will not be able to function. You must have seen you are keeping 18 degrees for a neurosurgery. Neurosurgeon will be sweating. You want to have one more gown, but he says, what is this? AC is not functioning and all. Isn't it? So you will not be able to function if it is a high temperature. So maximum temperature you can function, all OT personnel can be around 25 degrees, not higher than that. And especially it is slightly above the critical temperature of an infant. So that is why you always keep a OT temperature to around 25 degrees for pediatrics. So that is one method of reducing the heat loss. What are the other methods of reducing the heat loss?
Pre-warming the OT table, sir. Pre-warming the OT table. Hot saline.
You can have a thermostatically controlled heated beds, OT beds, isn't it? So you can continuously heat the OT bed. That is one more thing. Okay, then
wrapping of the extremities.
Covering the child and exposing only that part which is required for surgery. Isn't it? As far as possible, you cover the whole of the body except the surgical site. Okay, then
warm fluids.
Yeah, no, not only warm fluid. Yes, very good. Warm fluids also to be used. And even antiseptic solution, what the surgeon uses for painting also should be warmed and then used. One more thing is the hot air or the warm air. Like, you use warmers, isn't it? So body warmers like, bear hug. Many of our the pediatric patients we are using, and long procedures in adults also we are using this. So that's why it is very important to maintain what are the problems if the child develops hypothermia?
Child develop hypothermia is more prone for ventilated depression, metabolic acidosis.
You are ventilating. There is no question of ventilated depression. You are ventilating, isn't it?
Metabolic acidosis.
One is metabolic acidosis, right? Then what happens to OD?
What happened?
ODC go shift to the right.
Shift to the left.
Left.
Because of temperature. Decreased temperature, left. Increased temperature, right.
Right.
So that is another problem. And the most important problem as far as the baby is concerned, if the baby develops hypothermia, is what?
Late recovery from...
Delayed. That is the most common problem. So the baby will not come out of your anesthesia. So that is one of the major problems. So that's why you have to maintain the body temperature of the baby and you will not allow the baby to go for hypothermia. And another important thing is you may have to continuously monitor the temperature of the baby. Surface temperature or the core temperature has to be continuously monitored, especially when the baby is posted for major prolonged surgeries. Okay, that is about the temperature. And what are the different mechanisms by which the baby can lose weight, lose heat?
Open surgeries.
No, what are the mechanisms by which the baby can, or even adult can lose heat?
Conduction, convection, radiation.
Yeah, conduction, convection, radiation, and evaporation. And which is among these, which one is the most common to produce heat loss? Percentage of heat loss, highest percentage of heat loss.
Convections.
It is radiation. That is why, you continuously maintain a higher temperature around the baby by using hot air or warm air being blown. And also the OT environmental temperature, you keep it on the higher side, isn't it? So these are the mechanisms which you should always know. Thermoregulation is commonly asked as a theory question also. Okay, now coming to the liver and kidneys. Any change? Physiology and anatomy.
The GFR.
Pardon?
So liver, it is larger than the body
So
size.
the kidney, again, there is only 1 million nephrons compared to 3 million nephrons in adults. So because of that, reduced GFR, so reduced excretion of your drugs and the metabolites of the drugs. So the baby can have a prolonged duration of action of all the drugs. So that you should always know about. What about the liver?
Liver is comparatively large to the size or body size.
Okay.
Enzymes mature by the age of 3 to 6 months.
Okay, so especially, there are two phases of metabolism, isn't it? Phase 1 and phase 2.
Phase 2.
And which particular phase is more affected here? Is it phase 1 or phase 2?
Phase 1. Phase 1.
Yeah, phase 1.
Mm.
Phase 1 is, oxidation, reduction, alkylation, dealkylation. All those things are phase 1. Whereas glucuronidation is phase 2 or conjugation. So phase 2 is not affected much. So phase 1 is affected more. So majority of our drugs, they undergo phase 1 metabolism. So naturally, there is prolongation of the effect of these drugs. So you have to be extremely careful in using drugs which are getting metabolized from the liver and getting excreted through the kidneys. Okay, what about the CNS? About the CNS and anesthesia problems. What about the mark of these pediatric age groups?
Keeping higher MAC.
Higher MAC is required.
Isn't it? What is the MAC value of sevoflurane in an infant?
4 to 5, sir.
Adult, what is the MAC value?
2
MAC?
2 to 2.5. 2.5.
1.8 to 2. In infant and neonate?
4 to 5.
It is 3.2. 3.2 to 3.4. So the requirement is slightly on the higher side. Because the MAC is increased. That is one thing you should always know about. So what are the other things as far as CNS is concerned? What about the CSF volume?
Volume is more, sir, compared to
in the spinal cord.
Spinal cord.
Volume is more or less?
More, sir.
More, okay. So because volume is more, what is the effect? As far as
we are requiring more local anesthetics.
More local anesthetic, especially when you want to give a spinal anesthesia in these infants and neonates. What is the dose you have to use? What dose you will be using? For spinal anesthesia in a, infant or even an older child. So usually less than 5 kgs, you use 0.1 ml per kg body weight of bupivacaine 0.5%. Less than 5 kg child, 0.1 ml per kg body weight. For example, if the child is 4 kgs, then you have to use 0.4 ml. Okay, intrathecally. So if the child is 6 to 15 kgs, it is 0.08 ml per kg body weight. And if the child is more than 16 kgs, it is 0.06 ml per kg. So just remember 0.1, 0.08, 0.06. Less than 5 kgs, 0.1. And 6 to 15, 0.08. And 16 and above, it is 0.06 ml per kg. Okay. What about the anatomy as far as region anesthesia is concerned? Especially central neuraxial blocks. Any anatomical changes which you have to know about when you want to give a caudal block or spinal anesthesia or epidurals? Where the spinal cord ends?
Where
the spinal cord ends in adults and where the spinal cord ends in infants?
L3, L4, sir. L3 in Pediatrics.
So,
Infant.
lower border of L2 or upper border of L3.
L3.
Isn't
Yes,
it?
sir.
Whereas in adults, it is lower border of L1.
L1, upper border of L2. L2.
Okay, so what we will do is we will continue to discuss about few things about the regional anesthesia in pediatrics. It will take about for another 5 minutes, and then we'll go to anesthetic management of this child tomorrow. So we'll spend about half an hour on the anesthetic management, and then we will take up the tonsil. It will not take more than 1.5 hours for tonsil. So I'll be finishing tonsil also tomorrow. Okay, because it is 7:05. So anything there in the chat box? There is nothing in the chat box. So if you have any doubts, we can clear off the doubts in the beginning tomorrow, 5 minutes, and then we will go into the CNS changes as far as regional anesthesia is concerned. Just read and come. We'll just discuss about 5 minutes, and then we will go into the anesthetic management of this child. Okay, Vignesh, and
Thank you. Thank you, sir.
yeah, okay then. Right. Tomorrow we'll meet again at 5 o'clock.
Sure, sir.
Bye. Good night. Good night.
Good night.